All right, good afternoon, everyone. It has just been bon appetit. It has just been absolutely perfect from at very first this morning up until now. And now we have even more. You know, there's a saying that as your program continues and grows on, that you kind of diminish a little bit. Well, not so the case with us here. We've got two really wonderful panelists who will just be able to share with you information that you'll be glad that you stayed around to hear. This session is entitled Behavioral and Mental Health, and we have two speakers, Ms. Mara Blitzer and Ms. Jovonni Spinner. There you go. Mara Blitzer is a Senior Policy Advisor to the Deputy Assistant Secretary of the Office of Multifamily Housing Programs at HUD. Ms. Blitzer joined HUD in September 2013. Her work consists of advising the Deputy Assistant Secretary regarding energy, senior housing, and homelessness policies and supporting the Director of the Program of Administration's office in that office to make multifamily programs and services responsive to stakeholder feedback and to approach policy development in a strategic and transparent manner. Prior to starting in government service, Ms. Blitzer worked for 15 years as a developer of affordable and supportive housing in the San Francisco Bay Area and in New York City. Most recently, she was a senior project manager and sustainability program manager at Tenderloin Neighborhood Development Corporation. She holds a master's degree in real estate development from Columbia University and a bachelor's degree from Amherst College in political science and Spanish. Ms. Blitzer became a LEED Green Associate in 2012. I'm quite familiar with LEED. Very good. Then the next panelist we have is Jovonni Spinner, a certified health education specialist, has over 10 years of experience working with nonprofit government agencies at the state and federal level in the public health and healthcare field. Her skills include program planning and implementation, evaluation, data analysis, health promotion, and public policy. In her current position, she provides oversight for program evaluations for the division's health education programs and is the deputy project officer for a contract overseeing the planning, development, and implementation of strategies for the Community Health Worker Health Disparities Initiative. She is also the liaison for the NHLBI, which is the National Heart, Blood, and Lung. I do that every time, don't I? Lung and Blood Institute for HUD partnership to implement heart health programs in public housing, where she provides technical assistance and oversight for program implementation. And now sit back and really take in all that you will be able to absorb this afternoon. And Mara, we'll start with you.
Great, thank you so much. Hi, everyone. Thank you all very much for having me here. I am humbled. You could tell from my background that I really don't have a lot of experience in health. I am a consumer, but I'm not a health professional. And I'm actually quite pleased to be here today because I'm not a health professional. I am a housing professional, but we often work quite in silos. So I think it's quite important that HUD is here. I have colleagues coming tomorrow as well, and I think it's really great that we are here to exchange ideas. There's a lot more opportunity for collaboration, perhaps, than we take advantage of sometimes. So you have to forgive me in advance if I use acronyms or words that sound unfamiliar. I listened to the last 20 minutes of the previous presentation, and probably every other word was something that I didn't totally understand, and that's okay. Probably the first part of this conversation is to have a conversation and to admit where we don't know. So I was a little bit lost in the previous session. So I want to give you a little bit of an introduction about HUD, and one other small thing about myself. In my role as a real estate developer, I had the great opportunity to develop a federally qualified health center for the Department of Public Health in San Francisco. The clinic is called the Tom Waddell Urban Health Clinic, and if you are ever out in San Francisco, it is a pretty fantastic place, and it was designed specifically to serve folks who had been homeless, have experienced trauma, and it was a very profound experience for me working with healthcare providers to develop the space that would work most effectively for their clients. I'm curious about who's in the room. Who's a primary care provider? Couple? Senior services providers? None? Couple. Okay. Has anyone ever wanted to prescribe someone an apartment? One of the most common things that I have heard when I've been speaking with people in the healthcare field is they say to me a lot, I really wish I could just provide, give someone a script for an apartment, a voucher for housing. It's a really critical missing piece, I think, in our country's healthcare approach. So that's what I'm here to talk about. I've been asked today to talk about what healthcare providers should know about aging adults who are living in affordable and assisted housing, and to identify any innovative housing options available to older adults, and whether there is funding available to support increased health-related programs at federally assisted housing. But I have 10 minutes to give this presentation. So I'm going to try and touch on those things, but I want to, I think, take a little bit of a step back and let's see, I did that wrong. Yeah, talk about us. So HUD is the primary federal department addressing housing and community development needs, although we are not the only ones. U.S. Department of Agriculture also has a significant housing program for low-income Americans, as does the Department of Treasury. You might wonder, why does the Department of Treasury have anything to do with housing? They actually are the source of a really important program called the Low-Income Housing Tax Credit Program. I'm not going to talk about that today. But one of the themes of what I will be talking about is that HUD is less and less in the business of capital development, the bricks and mortar part of housing, and we increasingly rely on Treasury to do that for us. So our mission is to create strong, sustainable, inclusive communities and quality, affordable homes for all. Sounds good, right? Who's eligible for our programs. It really differs by programs. We have many, many of them, but they're all based on family size and household income. And we talk about income in terms of area median income. We have terms like low income, referring to people who earn up to 80% of area median income, very low income, referring to people earning up to 50% of area median income, and 30% of area median income as extremely low income, and that's really the target group of people when we're starting to talk about HUD's efforts for housing for seniors. And just to give you a point of comparison, 130% of federal poverty is roughly equivalent, depending on where you are, but roughly equivalent to about 30% of area median income. So the groups that are Medicaid eligible are typically in the 30% of AMI or below group when we're merging our housing and health worlds. What do we mean by affordable? I think this is really important. Affordable is relative. When we talk about it, we're talking about an ideal of a person spending no more than 30% of their income, their gross income, as rent. And in most HUD-assisted housing, that's actually how the payment structure is set up, where the tenant will pay 30% of their gross income as rent, and HUD will pay the difference between that amount, which if you are on Social Security income might be around $850 a month right now. 30% of that is about $200 a month, and there's pretty much nowhere where that will cover an apartment. So this sets up. I'm going to go back to that one. Sets up just a little bit of information more about who we are and who we serve. This slide right here, I took it from a different presentation, but I put it up there just to show we're all kind of in the same boat as far as regulatory complexity. Everyone who works with the federal government understands how complicated it is to get down to the level of a service to a human. When you're doing that in the realm of housing, we have our 3 federal agencies that are providing the funding for housing, and state agencies and local agencies, public housing, local continuums of care that are providing housing and services for the homeless. We have private and nonprofit developers, and owners, and we have financial institutions, sort of the banking and lending industry. So that's kind of our world. And frankly, if we were going to get a lot more fine-grained, we would put our health institutions right here up on the chart as well. So about 5.5 million people receive assistance through HUD's rental programs. As I said before, people in HUD housing spend 30% of their income as rent. We have 3 primary categories of housing, and I mentioned this mostly to peel back the onion a little bit. HUD has 9,000 employees. They work in all 50 states. And Jovonni and I were talking right before the presentation about HUD, and she's going to talk with you about a joint program with our public and Indian housing department. And I have never met the folks that she's worked with because our office is so large. But we have our public housing, which serves just over 1 million households, and somewhere between a third to a half of those are seniors age 65 and older. Our second primary assistance program is tenant-based rental assistance. It's now called Housing Choice Vouchers, but you might hear people call it tenant-based rental assistance as well. That's the largest support program of all of them, a little bit more than 2 million people. And then lastly, our project-based rental assistance program. That's where the assistance is based in a building, goes with a building instead of with a person. And has just over 1 million households. I work in the department that focuses on area number 3, the project-based rental assistance. And our primary housing program for seniors, the Section 202 supportive housing for the elderly program, fits into that last category. We have just under 1 million older adults living in HUD-assisted housing right now. So I think we had before 5.5 million households, about 1 million of them. That's about 20%, just under 20%. That number is expected to rise dramatically in the next couple of decades. So I have just a couple more minutes and a lot more slides, but I want to talk a little bit about Section 202 supportive housing for the elderly. It might be something that you have heard of. We have about 7,000 buildings that amongst them have more than 400,000 units. Our residents generally, and I use these with love, they're old, they're poor, and they're frail and at risk. Their median income is less than $13,000 a year. Their median age is 73. That median age is expected to rise also dramatically in the coming years, and nearly 40% of them report having one or more disabilities. I'm going to talk a little bit more about things that we're learning of late about our residents. I'm going to skip the slide. We can read it in the handouts later, but the gray tsunami is coming. We might already be on the top of it. It's big. It affects HUD. It affects all of us. We have a dramatic shortage of affordable housing, specifically for folks who are older than 65. This next chart is a little bit about how much we at HUD spend specifically on housing for the elderly. I mentioned before that Section 202 program, which in the past paid for both the capital costs of building a new building or renovating an old building. It offered rental subsidy, and it also offered really critically funding to offer a service coordinator at the property whose job it is to connect residents with community-based services of any different kind you can imagine. The budget in 2003, you can see, was nearly $800 million. As time goes on, we're just under $400 million in our current fiscal year's budget. So that is a trend that looks pretty similar with other programs within HUD that you might be familiar with. The Home and Community Development Block Grant programs also have not quite as dramatic as this, but they too are down in the above 25% over the last decade. So if we were going to take the chart of the number of people who are aging and the number of people who are aging and extremely low income, and we overlaid it over this chart, which is how much money we're spending on 202, they cross. So in light of that, at HUD, so why would someone who's kind of a policy wonk be here in this conversation? One of the things that we're doing in my office is having to go back to the drawing board and pull up our research and do some research to make the case that housing for the elderly that's low cost and quality and that offers support services to help people age in place and not need to go into more expensive institutional care is important. I think everyone in this room would agree that that's true, but when we at HUD go to our funders, to Congress, to make that point, they themselves are skeptics. So we are looking right now at identifying best practices, and we'll hear a little bit about some of those in a minute. I like to sort of simplify it. Like, we want to show that people are happier, healthier, and not going on to higher costs of care in our housing. So there is an emerging body of research work that has been coming out of late, and I'm going to skip to this one right here because I think tomorrow this report will be released. It's called A Picture of Housing and Health, Medicare and Medicaid Use Among Older Adults in HUD-Assisted Housing. And if you could say that backwards, you get a prize. But what it is might seem small, but what it was they wanted to see whether, with some simple information, a person's name, their date of birth, their social security number, and their street address, whether they could match that person's information coming from a HUD administrative data set with an HHS administrative data set and see if they could accurately connect those two sets together. And in the 12 cities that they did this study, they were about 93% of the time able to do that, which is extremely exciting for those of us who care about older adults and affordable housing, because now we have a way to use big data to follow our people. So the study will be coming out this week. You should check it out. Our research and in our Policy Development and Research Department, PD&R, they tend to be quite cautious. I myself am really excited about this. Doesn't really tell us much. It does tell us essentially what we knew, which is that folks that live in HUD housing are sicker and poorer than folks who are living in community. That isn't surprising. We were a little bit hesitant to put that information out there in the world, lest someone take that and twist it into a conclusion that we wouldn't really want them to draw. But we really see this as an amazing opportunity to help us get to where we want to go, which is some public support for important work that needs to be done. This slide states something that you all probably also know, which is that keeping someone happy, healthy, and housed not in an institution is significantly less expensive than having someone live in a nursing home. The numbers are pretty dramatic. If it costs around $20,000 for a person to live in HUD 202 housing, including all the wraparound services, and an average of $50,000+ for someone to live in a nursing home, there's a lot of reasons why we would want someone to stay in that lower level of care as long as they can until it is truly appropriate for them to be in the nursing home. So upcoming for our Section 202 in fiscal year 14, we were appropriated $20 million to do a demonstration project, and we will have a notice of funding availability coming out in the next 6 months or so, seeking partners in this project. And we will put out money both for the costs of providing services, which for us includes rental subsidy as well as service coordination, and we're looking also to support part-time nurse. That's new for HUD to pay for direct healthcare. Typically, we don't do that. We will be studying one of the 3 service models that I skipped over it, but the Lewin group did a study looking at what some different options might be for us in a demonstration, and we've picked one of those models, and we will go forth and evaluate probably for the next 5 years. But the money is now available to us. We'll be putting it out there. And we really can't wait to see how it all unfolds. We think the combination of the $20 million appropriation and some additional monies from another part of our account that we actually will be able to serve more than those 3,400 units. And we'll be doing that. Some will be doing some contracts for services only for existing 202s that do not have them currently, and some with rental contracts and services. So lastly, I just wanted to put out some names. These are the folks who are on this list: Leading Age and Stewards of Affordable Housing for the Future. They call it SAFE, because we need a good acronym for just about all that we do. Those are two groups that work very closely with HUD on the development of our 202 supportive housing for the elderly program, and they're good people for everyone in this room to know, as are the list of owners and property managers that are at the bottom of this list. In your communities, you might know them. Most of these are national groups, and within the 202 program, and actually this is true for all of our project-based Section 8 assistance, most of the properties are owned by a relatively small group of owners, and then the rest of them are owned by owners who only own one property. So we have 80% of the properties owned by 20% of the people, and then the other 20% are owned by individuals. Lastly, just some info on how to catch us on the web. I wouldn't profess to say that it's the easiest to find the information about the web, but I think if there's anything that I would want to leave you all with is this idea that what's on HUD's mind is on research, and with proving what we believe to be true, that housing that is affordable, that offers support services to residents, is really effective in keeping people happy and healthy as long as they can be, and aging in place in community. So that's going to be the next. As we see our budget numbers pretty low, we're hoping that we can reverse that trend and have them go up in the coming years once we're able to demonstrate with more certainty than we have been in the past that all of this is quite cost effective. And there is even a sliver of hope on our part that we would be able to get Medicaid, which traditionally has not paid for housing, to cover some of those costs of the services that are currently being provided by HUD, but that could be, if you wanted to take those services which are now being offered. I think my slide said that there's 1,300 service coordinators across the country. If we wanted to take that to scale, we might be looking to the healthcare sector to provide that. And there's all kinds of new Medicaid sort of demonstration type projects and funding that seems like are headed in the direction of being able to support those efforts in the long term. So that's it. Happy to take questions at the end, but there's really good stuff to come. So we'll hit it over to Jovonni for the next bit.
So I am going to give you a quick overview of NHLBI's partnership with HUD and how we've been using our materials to implement a community health worker program in public housing to address cardiovascular disease risk factors. So the issue that we have at hand is that we know older adults, especially those who are living in public housing, suffer from cardiovascular disease risk factors, and mainly related to environmental factors. So the risk factors for cardiovascular disease are not any different for older adults, but here are some specific statistics on some risk factors. So hypertension, about 70% of adults over the age of 65 have hypertension, 15% with cholesterol, and obesity is a big issue, and smoking is also an issue as well. Some of the contributing factors, when I was talking about the environmental factors on the previous slide, we know that people are living in communities where there are struggling school systems, they have low income, limited money, there are health literacy issues, they may not understand the information that's given to them by their providers, they have poor health, they have limited access to healthy choices, so they may not feel comfortable or safe doing physical activity in their neighborhoods, or they may not have access to healthy food options. They may be living in what we call food deserts. And of course, crime may be an issue for them as well, in addition to unemployment. Some may be retired, some may be disabled, but the bottom line is they have limited money and limited resources to make good health choices for themselves. Okay. Back in 2004, the Urban Institute put together a report that basically said kind of what we already know: public housing is mostly filled out with minorities, and that minority groups are at greater risk for cardiovascular disease. And that what's even more alarming is that people who live in public housing are affected more by these particular risk factors that I discussed than other groups of the same minority group. What we like to think of is place-based solutions. We know that where you live often determines different choices that you have to make in life. Some of the social determinants of health that I talked about, those are the issues that people are plagued with every day, that they're trying to make decisions. So you can think of someone who has a limited income. They're trying to make a decision between, should I get food this month, should I pay my electric bill this month, or should I get my prescription medications this month? So these are some of the issues that older adults are having to deal with. So our thought process is that the strategy should expose them to more positive experiences. And when you know more, you'll do better, essentially. And most importantly, meeting people at their point of need. We can't expect older adults to go out into the community to seek out these supportive services, so it's best if we can bring the programs and the information and resources right to their doorstep to eliminate one more barrier for them. So back in 2007, HUD and NHLBI entered into a partnership. So we started with 5 public housing sites across the U.S., and now we're up to about a little over 30 sites. So in a nutshell, HUD has the housing, HUD has the people, NHLBI has the resources for the people. So when you come together, we're leveraging each other's resources to improve health in public housing. So just a little bit about NHLBI's Community Health Worker Initiative. This is an initiative that we have been working on, and we have a lot of great resources and materials, but basically what we aim to do is not only build capacity, we want to train people from the community to be community health workers, which are essentially change agents who can help deliver heart health education in their own communities. We're also looking to engage communities because we know people who are a part of the process are more likely to benefit from the program when they feel involved and invested. And we use a systems approach with linking community education with clinical management where we can. We always ask our sites to try to partner with their local FQHC or other medical provider in the community. So therefore, if they do have residents that have elevated risk factors, they are able to refer them on to a medical provider where they can get the care that they need. And also just mobilizing communities as a whole. So here's a snapshot of the materials that we offer. We have 4 different manuals. All of them, we have 4, one for African American, one for American Indian Alaska Natives, one for Filipinos, and one for Latinos. They all cover the same topics, but what's unique about them is that they're all culturally adapted towards each group. So here's what's inside of the manual. The manual consists of 12 sessions, and we cover topics such as how to recognize the signs of a heart attack, how to manage your diabetes, your cholesterol, your hypertension, how do you eat healthy on a budget, how can you help quit smoking, how do you incorporate physical activity into your life. So those are some of the topics that we're covering in the manual. So like I said, it's all together is 12 sessions. The first 10 sessions are what I like to call the core sessions, where you're talking about the actual risk factors and how you can manage them. And the last 2 sessions, one focuses on a review and graduation, and the other session focuses on evaluation. So you can track your progress, and especially if you're seeking funding or you have to report back to your stakeholders, you can have some tangible results and information to share with them. We have 3 different distinct strategies. One is train the trainer, where you actually want to go in and train others on learning about heart disease. And then they will go out into the community to do community education. And then the third strategy is lifestyle and clinical management, where the community health worker can actually be integrated into the healthcare team and work with the local clinic or medical provider and follow the patient throughout their clinic experience. And they may help with things like setting up appointments, increasing their medication adherence, and helping them formulate questions that they can ask their medical provider so they can make sure that they're managing their conditions to the best of their ability. So you heard me use the term community health worker. We kind of use that as a catch-all term, but we also know a lot of people are using the manuals, and it doesn't necessarily just have to be a community health worker. We have diabetes educators, dietitians, health educators, community health representatives, but the bottom line is if someone is interested in the community and picking up a one-stop shop tool, they can use these manuals to educate others about heart disease. Some of the partners we work with in the past, obviously HUD is one, but we work with community-based organizations, academic institutions, other federal agencies, and area health education centers, as well as clinics. So in a nutshell, the CHW program is risk factor driven, it's culturally responsive and language appropriate. And along with the manuals, we have some supplemental materials. We have picture cards, which in this picture, you can actually see the community health worker kind of doing some one-on-one stuff. And there's a picture on one side, and then there's text on the other side where they can, do some one-on-one community education without having to use the entire manual. And also risk factor booklets that we send with the community participants so we can reinforce the key messages at home. The one good thing about the manual is that they are very flexible and they can be used to meet any community's needs. Like, for example, since there are 10 sessions and maybe you can get your community members out for, 10 distinct sessions, maybe you can condense them down to 4 sessions, or maybe you need to pick one session that you know that your community is most interested in. For example, the Boston Housing Authority, when they first started using the curriculum, they didn't want to do all 12 sessions, but they knew smoking was a huge issue in their community. So they started with the smoking session, and after that they were able to rally support around the community members, and then they were able to implement a no smoking policy within their housing authority. And once they started to gain some momentum, they went on to teach the other sessions. So just to wrap up, we know that the manuals are not the total answer, but it puts communities on a real path towards finding solutions that work for them. And we know that sustained interventions must be linked to address interrelated problems. We know firsthand that people are not only dealing with one issue, so we have to find multi-pronged solutions to help them meet their needs. And HUD continues to use housing as a platform to improve health outcomes for low-income people. And we need to expose people to something different. We need to expose them to positive experiences that will allow them to open their mind and change their attitudes, which will hopefully lead to positive behavior change. Okay. And here's my contact information. And thank you very much.
Thank you. Well, now we're going to open it up for some question and answers for both Mara and Jovonni. So if you have any questions, let's go ahead and start right away. We want to thank them both for the presentation, for taking the time to share information. Information is knowledge, so we appreciate that. Any questions from the floor?
Everyone's tired. Yes. Can you repeat? The question was,
Given that your funds are going down, and I'm sorry, it's on. Are you hearing me? You're hearing me now. Okay. Mm-hmm. Given that your funding is going down in some areas and the aging population is going way up, how is HUD going to make up the difference? And then a second question is, as you're giving out grants and 202 monies and so on, what consideration do you give to the developers and whoever else involved to make sure that they've actually planned some kind of health services, for residents?
Okay. Well, you didn't let me off easy for the for the afternoon. Both excellent questions. So as a federal government employee, I myself am not allowed to lobby you to lobby anyone else. Part of the answer I'll say that first, but part of the answer is, how are we going to handle our diagrams that are going in the wrong directions. My personal opinion when I kind of take off my HUD hat is that there needs to be a sort of constituent level advocacy effort to move Congress to become more amenable to spending money on housing and housing assistance, and then specifically for housing and assistance and services for the elderly. So unfortunately, although there's a great new study, it's called Home Matters, that came out this year that talks about American attitudes towards housing, and what kind of messages work from an advocacy perspective as we collectively might want to offer more affordable housing solutions. But that report doesn't say that affordable housing in the form of additional government subsidy, besides mortgage deduction for homeowners and the existing rental subsidies that we have, it doesn't seem to be making it up there. I think talking about housing as healthcare is an important piece of getting housing into the dialogue right now, because healthcare is so front and center as a national conversation, as a state conversation, as a local and community conversation. That is really on people's mind, and I think that there might be a way, if we start to talk about housing's role in healthcare. Jovonni talked about housing as a platform, for a platform for service delivery. Some people will go outright and say that housing is a form of healthcare and should be considered that way. There's many different ways to talk about it, but I think it is important to put housing and healthcare together in conversation, and that painful conversation is going to be the way to get the budget numbers back up where we need to be. I also, good local stories, when you get to your congressperson talking about the difficulties of seniors in your community, that's always quite effective to get a personal story into the staff and the member's mind. Most of us, regardless of what our income is, have experience with housing for the elderly in our own families and our own experiences. So it's whether someone's a resident of public housing or they're a congressperson, there's a lot of commonalities of experience. So I think we can use that in conversation. Specifically, we're also relying in concept on the demonstration project that we will roll out in the next, let's say 6 months. The money will go out because the money is going out to some projects that have not been built yet. It will be let's say 3 to 5 years before those buildings are built, and then we'll need to follow both the folks who received the intervention, which is rental assistance and enhanced service coordinators, as well as those who did not, to have the most robust evaluation we can. So we are somewhat in a holding pattern, but groups such as Leading Age and SAFE have really taken up this charge. I also think that trying to get a conversation into other senior advocacy organizations who have not taken up yet the topic of affordable housing is another route to that. And lastly, on the consideration of whether the providers of the 202 housing get credit or preference in our selection process, their experience is always considered during the selection process. And this time, because there's a rigorous evaluation component to the demonstration, we're also asking people up front to confirm that they are willing to participate in a demonstration and also to share with us what experience they have in working with evaluators. So we have people up front ready to participate in that aspect too.
Jovonni, I don't want to put you on the spot, but I know that your advisory groups have said probably, well, you've got numbers, you've got process, but what kind of outcomes? Have you been able, either on a pilot basis or with some descriptive statistics, for example, you used the Boston case, how many people actually did stop smoking at the end of the 12-week program, and then how many people were still not smoking 6 months later, or physical activity, where people walking around the building in some organized way that continued on beyond your 12-week program. Do you have something to share in the way of how you're handling that?
Sure, I'm actually glad you asked that question. I did not put any data in my slides today because I wanted today to be more of an introduction to the programs and really our work with HUD. But most recently, we had a set of 9 strategic champions demonstration projects who were using the curriculum. And before that, we've had other pilot programs. So we know that after people complete the 12-week community education session, that not only does their heart health knowledge improve, but also their self-reported, healthy behaviors improve, as well as their behaviors as well. So all of that definitely improves after the curriculum.
Any other questions? I have one for Mara. Later this week with our primary care and public housing program, one of the sessions will be on the topic of the changing landscape in public housing. And traditionally, we've seen the changing landscape as it impacts families. And seniors have remained intact with some redevelopment occurring with those senior high-rises. Can you speak to what perhaps is happening with the homes or the units of the seniors versus what's happening with families, and are there any cross-references that are happening there?
It's, to be honest, since I don't work in the public and Indian housing program area, so it's definitely not my area of expertise. But as far as there is an area of overlap with folks that I work with, so I can speak a little bit to if we're talking about the future. HUD has rolled out a program called the Rental Assistance Demonstration Program, RAD for short, which is intended to make sure that we can maintain our public housing units over the long term, complete the capital improvements that are needed, and provide the next 50 years of affordable housing on that platform. And part of what that is going to mean is actually moving units from the public housing platform to the multifamily platform. In simplest terms, it's moving from one type of rental assistance to another type of rental assistance for the resident themselves. The end result should be negligible from an administrative perspective, but their buildings should be in better shape because they now have the funds in place to fix the elevator more quickly, do major capital repairs that have been delayed for some time because we didn't have the appropriated funds to do other repairs. I think as well that you might see for seniors an opportunity as those units go from the public housing platform to the multifamily platform, where we have programs like 202. We have a service coordinator grant program. So we don't currently have the funding to serve more people, but we do have a bucket into which more funding could be placed. So you could imagine that service coordinators who currently in public housing, they may serve families or seniors. One of the principal and exciting service programs in public housing right now is not for seniors, it's the family self-sufficiency program. And I think that the early results are good for that. We might see multifamily specializing in seniors and senior services, and public housing looking more to the family. So those are kind of administrative sorts of changes, but I think from the perspective of a resident, it would means more faster repairs in the properties themselves, and potentially different access to building-based services in the long term.
Got it. Any other questions that we have? All right. And are we? Yes. Looks like we're right at the time, at the hour. And Joey has just reminded me that there are evaluations to be filled out. And if on your way out the door, you'll hand those over, we'd greatly appreciate it, so that our next planning effort will include some of your ideas and some of the things that we can incorporate with some of the other works that we're doing. And I'd just like to say thank you for hanging in there. It's been a long day, but I hope you will find that it was well worth your time today and that you'll be able to use some of this information that's available. And Rachel, will slides be available for? Okay. So you can also, it's been just a plethora of information, so if you'd like to contact later for information of the presenter slides, we'll gladly share any of that information that you may need. And again, thank you. Thank you for coming out today. Any other housekeeping notes that I have failed to mention?
No, we'll just see everyone tomorrow for day 2 or for the 2014 Health Center and Public Housing National Symposium.
Okay. One final thing, if I can take the liberty since I've got the mic. We have had a wonderful team. I know I said this earlier this morning, but they have been round the clock. Rachel sent me an email that was stamped 12:48 a.m. this morning for about this planning symposium, symposium. So I'd just like to give each one of them a round of applause that I really appreciate. We really appreciate pulling together the information. That's Rachel, Joy, Devin, and Johnette. Thank you so very much. Thank you again.